My name's Tiffany Wiles. I'm from CareHQ. This is a company that I started in 2013, looking at the deficits in ACFI and how people need to optimise. So what inspires me and who am I? I sort of looked at this from a past, present and future scenario. So from the past, the reason why I came into aged care in the first place was my grandfather. This is Reg. I remember a long, long time ago, we had a family gathering and we sat down and he said, you know, if you've got other things to do, you young people should go and do it. And it really saddened me in a way that he came a long way to be at this family gathering and felt that he was worthless within the family because of his age. So it really made me feel sad, and he's kind of my inspiration. So the present is me. I've been nursing for 30 years now. So you're generous to say 25 because, you know, perhaps I don't look that old, but good. And a lot of that has been in the aged care space. I did postgraduate training in gerontology, which is the study of aged people, I suppose, in 1992. So that's a long, long time ago now. And the reason that I'm doing it is for my children, both who have special needs, but I'm creating a future for them as well. So the issues in aged care is in care delivery. I've been in aged care, like I said, for a very long time and have been managing large facilities. I've been in areas where I've been in area management, clinical governance, and in key decision making. And the biggest problem has always been the funding model. Even when it was RCS, the funding model prior to this ACFI, which was all big and new in 2008, the people who delivered the care wanted to care. They weren't there to do the paperwork around funding. The funding was seen as just that extra job they had to do. There was a little red hen mentality. You know the story about the little red hen? Yeah, where it's not my job, and everybody then wanted to eat the loaf of bread at the end of the day, but they don't want to actually perform within the process of making the bread. So everybody had a little red hen mentality. Staff really don't know their residents well, and the people who are the key decision makers or the governors of the clinical area, the registered nurses, have no idea about the intricacies and nuances of the residents. They really just don't know. There are too many other tasks that are seen as a priority. And one of the things that I like to teach is that if people are clean, comfortable and content, the residents are well looked after. If you've got those outcomes looked at, you've got, you know, clean, comfortable, content residents, you have the opportunity then to focus on, you know, other things like your funding assessments. Oh, thank you. There's a lack of focus. There's not the shared skill and knowledge that's required about the funding model. I'm lucky that it's my sole focus. This is all I do. I'm not a facility manager anymore, so I don't have to worry about the P&Ls and the rosters and you know, all of those things. So my sole focus is only on the funding and how it works. The ACFI training doesn't teach the tools for success. I don't know how many clinicians in the room. 1, 2, 3, excellent. So I don't know if you actually attended the ACFI training. It just goes through a boring system on, you know, you need to tick this box and do that, and it doesn't actually tell you how to get that guts out of it. There are accountability issues, and now with the $10,000 fine for the facilities for fraudulent claiming, people are scared because they feel like their registration is at risk, which is a load of rubbish because it's a funding tool only. It's seen as something that disrupts workflow. and there's a disconnection between what staff want to do and what the expectation is. Thank you. And of course, when ACFI came in, they said, you know, it's less burdensome with documentation, but it's not necessarily the case, because every time, you know, we actually make advances, the government will put in a new business rule to say that we have to do this, we have to do that. And there's this, it's becoming very RCS-like, which is the previous funding model, and there's a lot of documentation around it. There's a lack of clarity about the non-mandatory assessments. I mean, we have mandatory assessment tools, but there is, what tools do we use to collect diagnostic data? We don't have anything that helps us do that. And there's a lot of, even in the electronic systems, like if we're recording a blood pressure somewhere, we've got to record it in, you know, the observation charts. We might have another area that we need to record it. Then we need to put it over into the funding tool. So there's this burdensome documentation. So there are some really big problems within the system. And nobody's actually thinking about ACFI. What we did when the funding model changed over is completely pull the tool apart. Took it right out, looked at it from a perspective of, next one please, incorporating the other aspects like normal ageing. We don't ever think, we always think about the problems. We don't think about how we normally age, but we've put that into it because it actually affects the way we assess people and the way we can claim on their ACFI. They're chronic disease issues, and you know, if you've got diabetes, there's a whole, just by the fact of having diabetes, there's a whole areas within the funding model that we can look at to see where we can actually optimise our income related to that. So we've developed tools that validate and document the evidence and fix the funding gaps. So with nutrition, the first question in ACFI. Nutrition looks at, the questions are around eating, but it also applies equally to drinking. But we don't even consider drinking. People might not need assistance with eating, but need vast amounts of assistance with drinking. So we look at whether or not people are dehydrated. We have a hydration assessment that gives us sort of a measurement of whether or not somebody's dehydrated. If they're dehydrated, wouldn't the solution be to assist them with being hydrated? And if people are dehydrated, there's a whole scree of other issues that are affected by that. So if you have dementia and you're dehydrated, your dementia is actually going to be worse because your brain's not functioning in its optimal space. And we have a training package. We usually do a 2-day training course. The first day we look at going through each of the questions, looking at all the issues related to each of the questions, and the second day we look at actually running through a claim that you might have and looking at how we actually go from point A to point B and get a funding claim at the end of it. Which is, you know, we go through it, it's your residence, your claim, and you get to keep that claim. So our goal is to ensure that every resident's unique and specific needs are fully funded. We want it to be really affordable. We want every facility, regardless of their size, to be able to afford us. We absorb all the expenses. What we do is come into your facility and charge you nothing until we make you something. If we can't make you money, we don't charge you anything. And that's the way we wanted to work it. We've got multiple service frameworks that we can so that we can help different sites at different levels. You might want to have somebody come in, do all your paperwork, all your ACFI, and just get your funding up. That's not really what I like to do. What I really like to do is be able to come in and build capacity so that you have an ongoing strategy for managing your funding and to move forward and stay solid. We look at the training methods that maximise care delivery beyond funding. So we're looking at best practice outcomes. We look at developing a care plan that also matches your funding so that it's contributing to your compliance and standard 2 as well. And our gold standard guarantee is that if we do funding claims for you and we lose money at validation, we'll refund you our fee. So there's absolutely no loss at any point to the client, ever. And I just want to demonstrate that just some financial increases, all have been validated with zero funding loss. Since we've started Key to Care, there's been no clawback. We've never lost a penny at validation. That's because our system and our evidence is really, really strong. So for 19 beds, an average daily increase of $121.88. That's a tiny little facility in the Western Darling Downs. We more than doubled their funding for ACFI and made them sustainable so that people could stay in their own communities. 40 beds, the average daily increase. Now this is the increase, it's not what their funding level is, it's just the increase. $127.27 today. This site increased by over $1.8 million. And a 20-bed facility, $129.66, nearly $1 million increase. What we want to do is be able to get money into facilities so that they can care for our elders. I don't want anybody to feel neglected or like my granddad felt, that we don't care about them. We need to care about people, and I put my money where my mouth is to do that. So the increases are really significant. We have improved results with ACFI. With outcomes for residents, we've got fewer falls. All the clinical indicators actually improve over time. Better skin care, mood elevation. People are happy because they're actually being treated, they're being touched. Improved pain management with the strategies. So we don't get the physio to come in for 4 days a week because firstly that's very expensive. The places that I usually go to are rural and remote. They don't have physios that actually can come in on 4 days a week like that. You might get them once a fortnight, but there's absolutely no opportunity to make any claims under pain management under question 12 with physiotherapy, allied health, and better nutrition. So we're looking at strategies to improve the outcomes for residents. Obviously, there's an increase in funding health, which I just demonstrated to you, which impacts service sustainability, the ability to attract and maintain quality staff, and then there's more resources per resident. So when I talk about increased funding and attracting staff, I mean obviously about workforce and aged care. The government sets the aged care award as a minimum. Nobody says that there's a maximum. You can pay people what you want, and if you've got a sustainable, good profit margin from all your funding streams, it actually allows you to pay for quality people. Pay peanut gets monkeys, that sort of situation. If you've got better funding, then you can actually get better staff. We improve the standard of documentation, and we look at giving you a vocabulary around the funding and around care. The way they're validating funding now is they're picking up on nuances of meanings of words, interpreting individual words. So we're looking at giving you a strong vocabulary for sustainable funding. We connect the care plan, the care that we're providing from the funding model into a care plan, so that the validators can say, can we have a look at your care plan? You don't have to produce it, but you can, because it's going to match exactly what your funding claim is. And we have a defined ACFI process with a clear allocation of responsibility. With workforce satisfaction, I find that staff understand why they do what they do by going through our process. And in understanding why, they're actually empowered to care more. We're able to, once they understand, they're able to focus on caring for their residents with increased job satisfaction, a sense of contribution to the bigger picture, and they're much more engaged in care. So really, that's what I do with ACFI. I don't know if all of you understand what ACFI is. Obviously, it's one of the funding streams that we use in aged care based on assessment of residents' needs. And I'll be here, like everybody else, to talk to you. There's one little story I want to tell you, but before I do that, part of what Michael was talking about is people, process and technology. So I've talked about people and I've talked about process, but I haven't talked about technology. I just want to mention to you that one of the things that we were looking at doing is expanding our services. To do that, we had to employ people. When you employ people, you can't ensure their quality and their commitment and all of that stuff. So we looked at using technology. We've developed a software to do exactly what I do on paper. So it's a paperless system, and it's something that we're looking at giving away to the government so that they can learn. It's powered by artificial intelligence and connects points of data with an association engine. If you want to know more about that, I've got some information there. But I'm a nurse, and that's my first passion. I'm technology, I'm lucky if I can cut and paste. So it's very interesting to be able to say I'm developing some software. But my little short story is, I've called it The Lie because it just happened to me last week. The very first client I had as an independent company, the chairperson of the board, I saw him in the street last week, and he said, "Oh my God, Tiffany, you lied to me." Really? How's that? He said, "You told us that you'd get us $1 million in funding." I said, "No, Paul, what I said is for 50 low care beds, I can increase your funding by $1 million. I said, "I didn't lie." He said, "Well, you did, because we got $2 million. So to be known for lying, I'm really pleased for that one. But the other things that people, the lies people tell, my goodness, I couldn't imagine it. But I'm really pleased to be able to be known for that lie. Thank you.
First question I've had, because as I get around, I talk about all these different partners depending on what people tell me are their problems. That's why I have a lineup of people in my head, because no matter what your gap is, part of my duty is to be able to say, I've got someone I can introduce you to. Tiffany, when I have this conversation with some group managers especially, and they say, why can't our people do that? Why can't my clinicians do what you do? Why is that?
Because, it's about focus. Like I said before, my focus is purely on this. So I've developed strategies. What I want to be able to do is get the money into aged care and keep it in aged care. Nurses are taught assessment skills. They look at what people can do. You have these assessments that says, can you walk to the toilet? Can you do this? Can you do that? Can you do that? But that doesn't guide care. What guides care is what you can't do. What I teach people to do is think polar opposite to what they're thinking now, and draw a line in the sand to say that's what you knew then, and now moving forward this is what you know now. So it's not a matter of not knowing, it's just you don't know what you don't know. And so I'm teaching a different way of thinking.
We see that they don't know what they don't know across aged care all the time. Are there any questions for Tiffany?
Well, of a very interesting point you mentioned, with your service, you will charge after the facility has increased the funding. So how do you know how much funding they have increased?
Okay, so what we do is at the beginning of the service, the facility provides their Medicare payment statement. That's the baseline. From that point, we then move on to making a projection about what the funding could be. We do case conferencing and we question staff. And from that point, we put funding claims in. We allocate time to put the funding claims in. No funding claim ever goes into the government without me checking it. Personally, I check it, every one of them, for congruency, for information, and over time, I provide every time we put a funding claim in, I also provide a report to the facility about any gaps that they might have, and so they fix up those. It's like an audit report. They fix up the gaps before any claim goes in. That's why I can say they all validate, because they're checked and rechecked. And even when we have to do a mandatory reassessment, there might not have been any changes, but I still check again. So it's a matter of checking. But I also, the invoicing is done monthly, only after you get paid from Medicare.
So what's the time frame from this funding from this level to go to this level?
It depends.
It gradually go and reach point.
It gradually goes up, but it depends on the resources that you want to put to increasing the funding. So we look at, so if I go to your facility and you've got, say you've got 100 staff, you can give me 3 people to case conference and work with that know those residents. We work through the information slowly to begin with. Over a 12-month period, I'll come into your facility quarterly or whatever is negotiated and build capacity with your staff. So that individual case conferencing is the point of learning. And it's really, really important to have that reinforcement over time. And that's what solidifies that change in thinking. So there's no upfront charges. We charge you monthly only after you get your monthly statements from Medicare. There's no out-of-pocket expense with it. And you know, we're not in direct competition with anybody. There is plenty of opportunity to assist everybody with their various support mechanisms. And, you know, we're very small. The people that I target generally, because it fits well with my soul, is the smaller, not-for-profit, standalone providers. I kind of think that the bigger providers are big enough to have the capacity, but often they don't.
Very true.
Often they don't.
Round of applause for Tiffany, please.
Thank you.